Well, let's go piece by piece. Why don't we start by focusing on gram negatives? I don't know, we could have started with gram positives, but we'll start with gram negatives. And we'll use nosocomial specifically to imply healthcare facility acquired infections. So, what are the risk factors for an MDR healthcare acquired infection gram negative to start with?
So the risk factors for an MDR gram negative are diverse. And they basically include a number of issues related to the patient and their underlying immune system status, whether they're, frankly immunosuppressed, they've had a stem cell or a solid organ transplant, they're on corticosteroids because someone hallucinated a reason to give them corticosteroids.
There's a lot of hallucination at your hospital.
I think there's a lot of hallucination in medicine. We do a lot of treating ourselves because of a lot of cognitive biases about loss aversion.
Okay.
But I mean, so there are things we do to the patient. There are things the patient brings with them, their diabetes, their renal failure, their chronic comorbidities. There's the severity of illness, right? If you're on a ventilator and you're sick as snot, you're at higher risk for these things. And critical illness itself turns out to be immune suppressing, especially given the literature we're learning about reactivation of CMV disease in that population. And then there are other things we do to the patients that violate their mucosal barriers. I'm putting in tubes and lines in places that allow biofilm to grow, which is basically a fertile ground for bacteria to overwhelm, and I'm injecting pus into the body some way. The point is, all of these essentially also are markers for antibiotic exposure. And prior antibiotics consistently, and there have been meta-analyses over and over again that indicate that it is the antibiotic exposure that selects out for a resistant pathogen. And the tonnage of antibiotics used in the patient is linearly correlated with that risk. And so that's really crucial because in addition to, I can't fix how sick they are when they show up. I can't fix their immune status. I occasionally have some role and control over getting lines out, but I may not be able to. But I certainly can control what they're seeing and what they're getting. And the problem, though, is these risk factors are heterogeneous, but they're also nonspecific. It's not like this group of risk factors means you're only at risk for CRE. This group of risk factors only means you're at risk for MDR Pseudomonas. The list of these overlaps substantially, and often you need to think about what's the epidemiology in your hospital. I mean, if you don't have CRE, the patient's not at risk for CRE, but it would also be helpful to know sometimes what the patient's been colonized with or infected with in the past.
Okay, and clearly, I think what you implied is that if the patient had an MDR infection in the past, guess what? You've got it again, or at least that has to be in your differential.
Absolutely.
And tell me about long-term nursing home, long-term care, SNF care, all of these environments which are not in the patient's home and where they're in contact with lots of other patients and the healthcare community.
I mean, I think the literature convincingly show that those places breed resistance because they are the last Wild West where there's no focus necessarily on good infection prevention and there's very little focus on antibiotic prescribing. And so there's a lot of, for lack of a better term, drive-by medicine, and people run in and run out and no one's taking ownership of the system, and those patients bounce back and forth to the hospital, especially given how we've designed some reimbursement schemes in this country. Mm-hmm. And so they bring back with them the problem that we may have started but was finished out there, and then all of a sudden it comes back to bite us.
Yeah, I was going to say, to be fair though, whatever your view of the drive-by medicine is, we send a lot of folks who've had a ton of antibiotics, right, over to an LTEC.
Right.
And they just sit there sharing bugs, right?
Yeah, I mean, largely everything that Andy talked about is a risk factor. Those are those patients. They're poster children from that standpoint. So yeah, it's fair to say that they get some of that antibiotic exposure with that from us. They get some of that resistant epidemiology of the hospital, but I think everything's kind of on steroids when you look at what's going on in that long-term care facility.
I mean, that's an interesting area. And whether or not, I mean, let me lay this out this way. We send in a whole bunch of people who've had a lot of antibiotics in the acute care facility. They go to an LTEC. Now they get sick. And the doc is confronted with, this patient had resistant bugs in the hospital. I can't get all the cultures every day. This is an LTEC. I'm just going to blast away. Now, I understand that. And to some degree, the logic isn't all that wrong, is it?
Oh, actually, I think it's fundamentally wrong.
Okay.
Because the logic misses...
I picked him for a reason.
Yeah, well, but the point is often in those, what we see is that those patients never have cultures taken in the LTAC. I mean, I have no qualms with anyone starting broad spectrum antibiotics so long as they're making the commitment to figure out a pathway off that ramp.
Okay.
Right? I mean, I know that as an intensivist, I'm sure you as an intensivist feel the need to have access to the antimicrobials that you feel are going to guarantee appropriate therapy, because other than fluid resuscitation, that's pretty much all that saves lives for a severe infection. However, as I tell my house staff, if you start an antibiotic without having a way to get it stopped, then you're doing a disservice to the patient. And what we see is when we ask the referring providers who are sending us patients from the LTAC, well, when they got sick 3 days ago, did you get a culture? And there's just silence on the phone. And it's often because they actually don't have access to microfacilities there at all.
I was going to point out, it's easy to be hard on these people,
Yes.
but sometimes they're at a severe disadvantage.
Right, and I understand that, but the point is, now what am I treating? And there's also a resistance, more so I think in those facilities than in the institution, and again, I understand why, because of the lack of monitoring, to never stop the antibiotics if they found an alternate diagnosis. And again, my favorite is the chest x-rays, kind of hazy, there may be some left lower lobe atelectasis, the secretions are yucky, well, I'm going to treat them for pneumonia, but then you gave them 80 of Lasix and the infiltrate's gone tomorrow. It's not bacterial infection. We stopped those antibiotics in the hospital. But I think in those facilities, because you can't get the monitoring as closely, you're afraid that if you stop too soon, there might be a consequence. I understand it, but that's the healthcare system we've designed, and we've got to deal with it.
It happens on the other end, too. Patients going from the hospital to the LTAC go on antibiotics. Maybe they've already been on antibiotics for 12 days. They need 2 more days, 3 more days. And for whatever reason, that stop date gets lost in translation when they leave the hospital. And 2 weeks later, I get a call from a pharmacist at the LTAC. Are you sure why they're on these antibiotics or how long they should be on them? And so that's a big point. That helps.
Is every patient in an LTAC guaranteed to see a physician every day? Often not, in my experience, no?
I think it varies from state to state. I know in the DC area, they have physicians who are dedicated to seeing them every day in the LTAC.
Right.
I know in other states where there are less, there aren't separate ventilator facility kind of LTACs, it varies.
Right.
But don't you think one of the biggest problems is there's no communication between
Absolutely.
the two healthcare systems?
Right. Absolutely.
We're doing
That was-
everything we can to just stay above water with the hospitalized patients, but at some point, we have to marry each other because we're never going to solve this problem. And there's a social responsibility to doing it right. And so this is the blame game. Like, they created it, gave it to us, we send it back. There's no continuity of
That
care.
gosh darn LTAC and
Right.
that gosh darn hospital.
And it's on both of us. And I
Right.
think that's a key thing. And I think that transition to care is one of the big areas for advancement. And it goes both ways. The problem is you need someone to again, if you're talking about it from a stewardship standpoint, you need someone to give that information to, which may or may not be there. And you need to have someone who will give that information back to you.